be starting this session after the break. Now, the next topic is pelvic ultrasound. So actually, I will highlight some important points what you have to see when you are putting a probe. Before this, there was one candidate with me, live interactive. And now if anybody wants to have a live interaction for this gynecological ultrasound, please raise the hand. Not this physical hand, that digital hand which is there in the more, the three dots, there is a raise option, hand raise option. You have to click over there and we will unmute your system from here instantly. So please raise your hand, whoever wants to have an interactive session with me for this male pelvic ultrasound. And keep an eye. Now, the point here is that you have to, first of all, actually, you have to keep embryology in your mind when you are putting a probe onto the female pelvis, because in embryology, we know that this uterus is having a relationship with the KUB, I mean the kidney, and if there is something abnormal in kidney, there is possibility that the abnormality in the uterus can be there, and vice versa also. What it means? It means that if you are suspecting a bicornuate uterus, don't restrict your scan onto the uterus only, slide up and see for the kidney. And if there is anything abnormal from the kidney, there are high possibilities that what you are thinking in the uterus, you are on right track. So don't restrict your scan onto the uterus only if you are suspecting any congenital abnormality, because if kidney is showing you some congenital abnormality, there are high possibilities that you are having some type of congenital abnormalities in the uterus. So now, then what you have to keep in mind? You have to keep in mind that not always your favorite, I'm using the word favorite, your favorite transvaginal probe is superior to the transabdominal probe, because this transvaginal probe is having a limitation. What the limitation is? Limitation is the penetration. Here I am having a less of penetration as compared to, here in transvaginal probe I am having less penetration than the transabdominal one. In transabdominal one, I am having more of penetration. It means that when you have to see more of the space, I'm keeping my language simple, because if you are are interested in more of space, I mean, if you are suspecting a bicornuate uterus, you have to see the contours. It means that you have to see more of the space. Then don't insert the probe, switch from transvaginal to transabdominal probe. And if your target is near the probe, I mean, maybe a polyp you have inserted over there and polyp is not far away from the transducer, then the choice of the transducer is transvaginal. So this is the point over here, because we are taking a CME here. This CME is not a course right now. We cannot elaborate each and every point. This gynecological ultrasound is of about 2 to 3 months. I'm repeating, 2 to 3 months daily. You have to give about a half an hour, 14 minutes per day. Will get complete, and here we are giving an introductory CME. Now, there are many muscles which you have to keep in mind. There is a pelvic space, a true and a false pelvis. This is the true pelvis and this is the false pelvis. Why I should know about the true and the false pelvis is that sometimes I am having a peniculated. Now, if I am having a uterus over here, and if the uterus is crystal clear, there is nothing in the uterus, but maybe that there is a peniculated fibroid. And if that peniculated fibroid is going in the false pelvis, like here, it is going in the false pelvis, I will be easily missing, because I am restricting my scan onto the uterus only. Uterus will be very clear over here, and I will be missing the the peniculated fibroid which is there in the false pelvis. Okay, there is some candidate, Dr. Madhavi, right now. So Dr. Madhavi, right now. Dr. Madhavi has raised the hand. Please accept that notation, and on accepting, say hello. Dr. Badi, am I audible?
Hi, sir. Yes, sir.
Yeah. So the point is that we have to scan the false pelvis also. Dr. Badi, how you are scanning the false pelvis?
We can go by abdominal. Are you
understanding question? Understanding question is more important than giving the answer. The uterus is here. Not trying to understand. The uterus is here. This is the uterus. You are putting your probe and you are seeing a beautiful uterus over here. Your beam is getting onto the uterus and there is nothing abnormal in the uterus, but maybe that there is a penetrated fibroid which is high up in the false pelvis. The point is how you will be able to scan the false pelvis. This is the same candidate who was previously with me. Now so there is something. Yeah, Dr. Madri.
So by convex probe we can see, no, sir?
Yeah, by convex only. How? What is the technique? What is that technique called as? Yes, no.
No, sir.
What it means? It means that you are not scanning the false pelvis. You are scanning the uterus only, always. Now see, if your probe is like this and your wrist, now see, if your wrist is not moving up, your beam will not get lifted. This fanning, this is actually called as fanning. Transverse fanning and the longitudinal fanning, sweeping rather, sweeping. So this tilting up, this wrist tilting up will get the beam hit. Now see, will get beam hit in the false pelvis. Otherwise, you will never be able to scan the false pelvis. So this is called as uterine sweeping. So make sure that you have done this uterine sweeping also. You can note it down. Then later on, you can ask for what is this uterine sweeping. But the point is, if you are not doing the sweeping, you are not actually scanning the false pelvis. And if there is anything abnormal in the false pelvis, that will easily get missed. So now, next is I'm not skipping between because this will take time. Now, the basic important point is that in this slide is that this is my trans abdominal probe and this is my transvaginal probe. In this trans abdominal probe, I am having a wider, try to understand, a wider field, but less is the resolution. In this transvaginal probe, I am having a narrow field, but the resolution is more. So here, the resolution is at an expense of the penetration. This is the basic important point over here, because you have to sometimes switch between the transvaginal and the transabdominal probe, and if you don't know this, you will not be able to switch between. Now, Dr. Madri, tell me honestly, have you seen any report? I am not saying that you have reported that. Have you ever heard of any report that there was a tube mass or a dermoid or anything abnormal in ovary, but somebody has operated it for a dermoid, for an abnormality in the ovary, but when somebody operated or you operated or somebody else, there was nothing inside. Have you never heard of this? That the report was abnormal, and when that patient got operated for a dermoid, for an endometrioma, for a gliomas, or anything abnormal from the ovaries, but actually those ovaries were crystal clear. Tell me honestly. Have you not even heard of? I'm not telling that you have done this case. Have you not heard of this?
Yes, sir. I operated myself based on the other report, like hemorrhagic cyst of the ovary. But when we got inside through laparoscope, there is nothing there. It was normal. So it's a negative.
Right. Now, these things happen very frequently. Why? Why somebody, let us discuss somebody, why somebody is seeing on ultrasound monitor an abnormality. It can be a hemorrhagic cyst, it can be this, it can be that, but actually it is not that thing. What makes that doctor to think of a hemorrhagic cyst when it was not there? Muscles. Muscles, if cutted transversely, will look like a mass. A mass, sometimes an ovary. And if I don't know that this is a muscle, I will very easily take this for an ovary, for this mass, for a hemorrhagic cyst, for a dermoid, anything. Now, how you will come to know, Dr. Madhu think, and others also, that I am not actually dealing with an abnormal ovary, but a cross-cutted muscle. Think. Others post in the comment box. Repeating the question. How I will come to know that this mass is not a mass, but a cross-cutted muscle? Think. Hurry up, hurry up. So, now see. The basic important point is that we are taking this ultrasound as a photography. We are thinking that we will sit somewhere and somebody will, wave a magic stick over there, and I will come to, I will do a good ultrasound with that magic stick. Magic stick is over here in your brain. So, lot of theory is involved. Then only you can make a good diagnosis or rule out a diagnosis. Otherwise, you keep on committing blunders. Now, if you will rotate a probe on this mass, and if this is a mass, this will not get in length. And if it goes in length, then you are actually dealing with a muscle. So the basic important point is that, this is again not a course over here. This is a CAB. I am having a time limitation over here. The basic important point, what I want to tell you is that in abdomen, in this female pelvis, I am having muscles, and these muscles, most of the muscles, no, see, this one, you can read it yourself. These muscles, this operator turn or video muscle, these are paired muscles. These are paired muscles. Not only you will think that I am dealing with an abnormal ovary, but you can actually label this for an ovary. So if you are having a bilateral mass-like thing, then think tens of times before labeling it, because maybe that you have cutted a cross-cutted, you are cross-cutting a muscle over there. And if this is the detail of these muscles, how they are looking like. Now, see, if I will not take this in context, you will easily label this for a mass. But when I rotate it, it is showing me, no, madam, no, sir, this is a muscle. So the point is that the cross-cutted muscle will look like a mass or an abnormal ovary, or sometimes you will label this for an ovary. So know your muscles. Now, this is a detail of these all muscles, how these muscles are looking like, and how they look on ultrasound. Now, normal uterus. Now, Dr. Madhuri, what is the, how much is the length? We all know that the length is about 7 to 8 centimeters, depth is about 3 to 4 centimeters, and width is 3 to 5 centimeters, and I have had about 1 centimeter for multiparous. You can note it down. But the main important point is that the question. Now, let's go to the question. Dr. Madhuri,
Sir.
this is a longitudinal section. Yes or no?
Yes, sir.
Now, wire from, I will take the length. I am taking the length. Yes or no? Am I
Yes, sir.
taking the length? Yes or no?
Yes, sir.
Yes. Now, question. Question is that, let me take another color so that you will better appreciate. What I am measuring with this blue, what is this? Is this depth or is this width? Other post in the comment box. You are each and every day seeing this type of uterus in longitudinal section. What I am measuring, if I am measuring this blue line over here, options. Is this depth or is this width?
It's
Others post in the comment box.
it's depth only, sir.
Yes, I got some comments also there. Depth. Yes, this is depth. But the point is, next question. Questions will make you understand. Wire is the, this is depth. Okay, this is the depth. How I can take the width of this uterus?
Rotate the probe and
Very good. So I have to rotate the probe. Then only I can take the width, because we have discussed the screen orientation. Width has to be taken from right to left. And there is no right and left when I belong to the section. I have to rotate the probe. What it means? It means that to take all these three measurements, length, depth, and width, I should have two sections. And one is the transverse and one is the longitudinal section. That is why the machine is giving you a dual mode. Dual mode is not to save the paper while taking the printouts, but to take the three measurements, and the three measurements only will give you an actual volume. Have you, Dr. Madhuri, not seen a report or not seen heard of a report that there is a polycystic ovary, and when you investigated it thoroughly, it was normal, or vice versa also? Wow, what vice versa? Actually, that was a polycystic ovary, but that was missed on ultrasound. Is that not happening?
happening, sir.
Why? Why it is happening? Because for volume, I have to do three measurements. What is the formula to calculate the volume? Length into depth with this volume divided by 0.55. But we have not to do that. Machine is doing. It is if you give the wrong measurement to machine will give you the wrong volume, and you are then taking that volume what machine is giving you for an actual volume, which is not. For volume also, I have to take three measurements, and these three measurements are possible in two sections, one in transverse, one in section. So know what wire to take. Now, the ovary for a premenopausal woman is 3 to 5 centimeters long and about 3 centimeters wide and 1 centimeter thick. Now, let me discuss this. This is our uterus over here. Now, where is the bladder? Bladder is here. Bladder is here. This is your very bladder. Now, the question is how I can make out whether I am having a retroverted, retroflexed, antiverted, antiflexed uterus. Is that I will be drawing some imaginary lines. One from the top of the uterus and another from the cervix. What is this angle over here? About a 90 degree. So if it is more of obtuse, what that uterus will be, Dr. Madhuri? Retroverted or antiflexed? If this angle is more of 90, I mean more obtuse, where the fundus will go? Fundus has to go this side. So that is a retroflexed uterus. And if this angle is more of acute, I mean 40 degree or a 50 degree lesser the angle, uterus is going over here and move the virgin over here. And you can add on the third line also then, which is passing through the cervix. And the previous one was passing through the vaginal strength. Now, this way you can make out whether this is anteverted, anteflexed, retroverted, retroflexed by these ligaments. Now, pelvic spaces. In pelvic spaces, what I have to keep in mind, I have to give many things in mind, but I am giving you some important highlights. This is bladder over here. This is your bladder. This is uterus over here, and this is the rectum. Now, let us see where is the anterior cul-de-sac and where is the posterior cul-de-sac on ultrasound. Keep this thing in your mind. Now, yeah, okay. Anterior cul-de-sac is over here. This is anterior, and posterior cul-de-sac is over here. See over here. Now, where this anterior and posterior will be on ultrasound monitor, where you will see is this anterior, posterior cul-de-sac. Dr. Madhu, yes or no?
Yes, sir.
Yes. Question. Where is anterior cul-de-sac? We have marked the posterior one. Where is the anterior cul-de-sac? Options. Is anterior cul-de-sac anterior to posterior cul-de-sac? Repeating. Is anterior cul-de-sac anterior to posterior cul-de-sac like here? Yes or no?
No.
Yes or no?
No, sir.
If no, why? If no, why it is not anterior to posterior? It should be actually over here. Why I marked it on red, but it is not there. Dr. Madhuri is telling me, and you are right also. Why it is not over here?
Let's. Sir, it is.
Now, please recall your anatomy. The peritoneum is anteriorly more shallow or more deep than posterior. Posteriorly, it is more deep, anteriorly, it is shallow. Am I right?
Yes, sir.
That is why posterior cul-de-sac is here, this one, and anterior is a bit up. This is anterior cul-de-sac, and this is posterior cul-de-sac. So the point is, anterior cul-de-sac is not actually anterior to posterior cul-de-sac. Where is the space of radius? Where is space of radius?
It's retropubic space, sir.
Yes. So this is the space of radius. Space of radius. Now, question. If I am having a moderate fluid in posterior cul-de-sac, that can spread up to the anterior cul-de-sac, yes. But if I am having more fluid posteriorly, I mean a severe fluid, I will be having obviously anterior cul-de-sac fluid. But if I am having more of the posterior cul-de-sac fluid, it will even go to the space of radius. Yes or no? Yes or no? Others, post in the comment box. Dr. Madhu, yes or no? Yes or no? Repeating the question. If I am having very, very severe posterior cul-de-sac fluid along with the anterior cul-de-sac fluid, I will be having some fluid in space of radius also. Yes or no?
No, sir.
Why?
It's not connected.
Very good. It is not connected. Now the point is on ultrasound, where this space of radius will be, where you will expect some fluid in case of a trauma patient or a post-operative case. I mean, in case of a space of radius will not have fluid which is coming from the posterior cul-de-sac, but in post-operative or in some trauma cases, there can be space of radius. Am I right?
Sir.
Yeah. Now, wire on ultrasound, I am having space of radius. This is POD, posterior cul-de-sac. This is anterior cul-de-sac. Where is the space of radius on this monitor over here? Anterior to bladder, we know that. But where we will see that? Over here. So you have to see anterior to the bladder for space of radius. See, ultrasound is all about the correlation of your anatomy onto the screen. If your correlation is missing and if you are not taught how to correlate, you will struggle whole of your life with ultrasound. So this is the basic understanding of the pelvic spaces. Okay, what else you want to discuss with me from this gynae ultrasound? Because this gynae ultrasound is very vast. We have to go for the follicular study, and this thing was not included in your CME, but anyhow, I took this also. What you want to discuss with me from this pelvic ultrasound, Dr. Madhuri, you tell me now, or if somebody is interested to discuss with me some subtopic, you can post in the comment box also. Yeah, Madhuri, tell me. Because there is some commenting. Do you feel that we let's discuss you? Do you have confusion in any diagnosis of the female pelvis, Dr. Madhuri?
Sir?
We will discuss that only. You want me to discuss any topic from female pelvis? Hurry up. Anything from female pelvis.
Sir, tell how to take exact length, width, depth of both uterus and ovaries, sir, if possible. Whether we are doing is correct or not.
Okay. Okay. I will take your question, but I have to switch the board. Yes. Okay. Now, what we will do? Give me the blackboard. Now, we will try to understand how to take the measurements of uterus, like how actually we have to take the length, the width, and the depth. We will take that. So we are setting the board for you. Okay, done. Now, first of all, we have to see for length, width, and depth. The point is, I have to see which section I am. When I am in longitudinal section, LS longitudinal section, the uterus will look like this. When I am taking the measurement from the fundus, including the cervix, I am measuring the length like this. So this is including the cervix. Being in longitudinal section, not in transverse section, being in longitudinal section. Now, that is length. So length is about 7 to 8 centimeters. Now, This is in longitudinal section. Now, when I rotate the probe to take the transverse section, this uterus will now look more round or oval. And if I am measuring from here to here, I am actually measuring, now see, this is anterior and this is posterior. We have discussed the screen orientation. Anterior to posterior will be the depth. Now, when I measure from here to here across, it is from right to left. Now, recall the screen orientation which we have discussed. When I measure from right to left, I am measuring the width. Now, if I measure from here to here, what I am measuring? I am measuring width. Oh, sorry. I am measuring the depth. So the depth can be measured. Depth can be measured in longitudinal as well as in transverse section. So by the split screen, rotating the probe, I will be taking all these three measurements. Otherwise, I am taking it wrongly. The same is applicable for the ovary also, because when I am taking ovary, I am taking the volume of the organ, and if I take the, I give the, let me erase this one, and if I give wrong measurement to machine will give me wrong volume. Now in transverse section, how the ovary will look like, and how in longitudinal. In transverse, it will be more of round or oval, and over here it will be more in length. Same thing over here. When I measure from here to here, when I measure from here to here, I am taking depth and I am taking width. And over here, when I am taking this length in longitudinal section, this is important. I am taking the length. Then only machine will give you the correct actual volume, whatever is there. So don't take volume in one section only. For volume, you have to take two sections and you have to give all this. Then only the correct volume will be given by the machine. Okay. Anything? Any more question or any more topic which you want to discuss with me? Dr. Madhuri is live with me, or if anybody wants to get live with me, they can raise the hand to have an interactive session, or they can post in the comment box. Okay. Okay, we are now moving to the infertility scan. Dr. Madhuri.
Sir.
You are seeing a triple line endometrium and you are getting happy. Not you, everybody is getting happy with the triple line endometrium. Let us discuss this triple line endometrium. There are actually three lines looking like A. Let me mark this. A, B, and in between this C, which is making it as a triple line endometrium. Question. What is this A about? Which line is that? What is this B? And what is this C? This is all about the triple line endometrium. I'm seeing three lines over there. The question is, what is this A line about?
So they are regarding endomyometrial.
No. Recall tunica, bassalis, tunica, functionalis.
Okay, layers of endometrium, sir. Tunica, basalis, and.
Yes, A is tunica.
Basalis.
Bassalis, right. What is the C? Then we'll discuss first B. Sorry, not C. What is the B?
It's
Others in the comment section. What is this B? Is the cavity line.
Yes, sir. Yes, sir. Cavity.
This endometrial cavity line. Now, what is the C? Any idea? Yes, no? Yes, no, hurry up.
No, sir.
No. Okay. Now, this C, if this A is vasalis, this C is functionalis.
Yes, sir. Functionalis, right.
Now, whenever you are having a thin endometrium, what actually you are having thin? This tunica vasalis or tunica functionalis?
It's functionalis, sir.
Functionalis. So now this will again take time. So the basic important point is that I am having three lines over here. These are the tunica vasalis, functionalis, and the the central line, which is the cavity line. So in this follicular study, you don't have to only concentrate onto the follicle. I'm coming onto the folliculometry now. Now, in this folliculometry, you have to keep equal eye onto the endometrium also. Because if your follicle is growing, then it is rupturing. Ultimately, it has to go into the endometrial cavity. Not actually the cavity, endometrial, but the uterine cavity, I would say properly, because it is there while it has to implant. And if my C is low, if my C measurement is low, what it means? If my tunica functionalis is thin, it will not get implanted and patient will have the menstrual abortion, and patient will never come to know that she is aborted because that is menstrual abortion. You can recall what is menstrual abortion, we will not discuss it over here. Anyhow, the point here is that the thin functionalis can also lead to the infertility. So the next topic what we will discuss is the folliculometry now. So we will take a short 5-10 minutes break and we will take now the folliculometry.